Hi everyone. Uh, Good afternoon, or good morning, and depending on where you are. Thank you for joining today's webinar. So entitled The Three E's. So here we'll just be looking at some of the core components that make up decentralized clinical trial platforms. So namely eConsent, electronic case report forms, and ePRO, so electronic patient reported outcomes. So in terms of the agenda, we'll have a quick introduction just from myself, and then a quick company profile overview. We'll go through the clinical trial challenges. So speaking again specifically to those that impact the efficiency of clinical trials and how decentralized clinical trial platforms can mitigate those. We'll look at the impact DCT platforms, and then we'll specifically look at the aforementioned core components. And then there'll be a brief overview of challenges with regards to decentralized clinical trial platform implementation, and then a brief Q&A session. And just quickly from myself, so my name's Ochanesia Anyanwu, that's for short, and I'm an R&D lead here. So with eCRF, Milo Healthcare, and my experience has spanned digital health in terms of specific therapy areas, areas such as rare disease, market access, health economics, and I've worked on scientific projects and clinical projects across North American, European, and also sub-Saharan African markets. So just quickly take you through the company profile. So here's our CEO, Sheb Sashani. And so we've established revenue of over 2 million euros across 3 years. And he's led on over 50 global trials and oversees the implementation of our new digital and decentralized clinical trial platform called Milo Healthcare. So I'll explain a little bit more of that later. And then in terms of our team, so we work closely with clinical advisors. So we have Professor Jan here, who's the head of clinical trials at St. Joseph Hospital. We're also working with Konstantinos, so an ophthalmologist who works out from Moorfields Eye Hospital in London. So again, he specializes in AI applications for medical technology. And then here's our board. So again, we have key individuals from industry and the commercial world. So just quickly on eCRF, so we are a clinical research organization. We help clients navigate regulatory particulars, so particularly related to the medical device regulation, so helping clients understand various challenges in order to get their medical device to market. So at the core of our offerings is helping clients generate high quality evidence required in order to meet the standards of key notified bodies. So we've founded in 2018, and since we've expanded, expanding our base of operations and working from the UK and Germany and also Japan. And in terms of therapeutic areas as well of interest, this now also includes chronic wound care and urology. And just to add to what I mentioned earlier, so we also have a decentralized clinical trial platform called Milo. And so again, this is a platform that can be used to generate real-world data, which of course can be used to generate real-world evidence. And again, this is something that we offer to clients who require our help with navigating regulatory particulars as it relates to the DR. So these are some of our key clients to date. And here are some of our clinical sites. In terms of the general workflow that we follow, so we work on various activities. So as they relate to the MDR specifically, we work on generating clinical evaluation reports. We also work on post-market clinical follow-up activities as well. And within this, we also support clients with using decentralized clinical trial platforms in order to ensure that the data for their medical device is as robust as possible. We run pre-market clinical trials as well. So as mentioned, we have the Milo platform, DCT platform, and we also offer technical documentation review services. So in order to support reimbursement. So again, leaning into the health economic side. So just to start with the main session. So challenges in clinical trials. So generally, I think it's well known that clinical trials they're incredibly expensive, and there's a lot that goes into R&D, and it's a unique industry in the sense that there are billions spent, but sometimes there's also a lot of waste as well, and it's kind of commonplace. So in terms of the differences between cost and efficiency, this is, I guess, an area that's been a consistent challenge for the global pharma R&D world, and also this also applies to medical devices as well. So again, similar challenges in that balancing expenditure against return. So in order to make sure that the trials that are conducted are as efficient as possible. So just leaning in specifically to clinical trials. So a significant proportion of the inefficiencies that we do see in clinical trials do stem from the recruitment process. For example, over 80% of clinical trials are delayed and cancelled mainly due to recruitment issues, and also delays can cost up to $600,000 per day for clinical trials. And just to further contextualize this, so when we look at phase 2 and phase 3, these have been observed to have been delayed by 4 and 3 months respectively. So this was some data that McKinsey gathered. So in terms of the transition to decentralized clinical trial platforms, I guess the draw towards them is the fact that they can help provide a more efficient way of doing them, and they can curb some of the costs significantly. So addressing some of the key efficiencies. So some of the reference data sets which have been provided show that DCT platforms could help reduce clinical trial costs by between 10 to 25%. And there was a paper published by Joseph DiMasi, 2022. So a tough center study which showed that decentralized clinical trials and platforms, so when applied to clinical trials, and so specifically between phase 2 and phase 3, could increase the value and the net present value specifically by $20 million, with a return on investment 7 times that amount. So again, this displays the value of decentralized clinical trial platforms and how they can really improve the quality, the efficiency, and the operational efficiency of clinical trials. And just quickly on momentum, so um, a lot of individuals across individuals and organizations across the life sciences, particularly in the post-COVID world, have increased their use of decentralized clinical trial platforms. So anything that allows for the remote conducting of clinical trials or provision of healthcare. So we have approximately 94% of research sites have used at least one type of DCT methodology. And again, as I mentioned, post-COVID, between 2020 and 2022, use of virtual or DCT technologies have risen by 93%. And so we've just talked about some of the issues with regards to the efficiency of clinical trials and recruitment. Another key issue is maintaining patients. So once they've been identified, ensuring that they don't drop out. And a key issue with clinical trials, which plays into the inefficiency, are the high attrition rates. So we're looking at around about approximately 30% or over 30% dropout rate in clinical trials. And one way to potentially curb this, again, this is where DCT platforms come in handy, is to provide a patient-centric way of doing clinical trials. So helping patients, stakeholders feel comfortable, so they're less likely to drop out. So just to start with, so we have eConsent. So this is just a general figure, so specifically for the US. So approximately over 70% of potential participants for a clinical trial, and they live more than 2 hours away. And so this is quite interesting, and it's quite important because it does highlight the importance of having a decentralized way of doing clinical trials in order to help patients and any other stakeholders take part. A simple definition here. So in terms of eConsent, we're looking at a way of obtaining informed consent from people taking part in a clinical trial using digital technologies. So again, we're talking about obtaining the informed consent of patients or any other stakeholders using hardware such as smartphones, tablets, computers, laptops. And just to quickly highlight, the eConsent is different from e-signatures. So e-signatures are a subcomponent, you can think of it that way, of eConsent, where they tend to focus on a specific document. So this could be like a regulatory or legal document, whereas eConsent, we're talking about the patient's informed consent of a particular study. So you can kind of think of it as being broader. So here we have different types of eConsent. So we have video-based eConsent. So again, with similar to almost a televisit, having a patient watch video or maybe even speak with the patient in order to understand, ensure that they understand their obligations within and their rights within a clinical study. We also have the lock and unlock form of eConsent, so whereby in order for a patient to complete a document, they need to go through the document, read it, understand it in order for it to be unlocked. So this is quite a good way to gain informed consent. So before they can almost go to the next part, they need to have understood the preceding section fully. We also have the in-person e-signature, so they may be in a clinical center or a hospital, wherever it is, and essentially they'll provide their signature, an e-signature, through hardware such as computers, and typed name with affirmative acknowledgement. So again, this is similarly, we're talking about input into a computer, and of course the obtained with the informed consent of the patient. We also have a remote electronic signature. So this type, they're becoming a lot more common. So you can think of a remote patient monitoring platform in particular, where, for example, a patient has an app and they sign and they consent to a clinical trial from their home or wherever it's convenient for them. So, for example, you can have platforms, so the ones provided by DocuSign, for example, which are integrated into such platforms. But essentially, it's consent which is provided remotely, and then this is quite simple, a scanned handwritten signature. So again, we're just looking at consent which utilizes digital technologies. So in terms of the key benefits of eConsent, so firstly, the remote function. So eConsent, again, when provided within a DCT platform, it allows the patient or any other stakeholder to onboard onto a clinical trial remotely, so wherever it's convenient for them. Again, in terms of patient centricity and increasing the likelihood that patients can come on board. If we have patients that live in rural areas, or we have patients that have impaired motor function, this of course will be very important. So having a more inclusive approach to clinical trials, the remote function can provide patients with the convenience that they need. And also, as a digital way of obtaining consent, any stakeholders within the clinical study, and provided they have the necessary access permissions, if required, where they need to share data, this is something that can be easily done. So as opposed to a conventional paper-based way of obtaining consent. Next, we have regulatory compliance. eConsent provides a very neat format that can be easily updated with minimal disruption. The changes can be easily tracked, and as a digital file, there will be metadata which will provide regulatory authorities with data that they can use during auditing. This is also very important, patient comprehension. So again, going back to patient-centric methods within healthcare, one of the great things about eConsent is the ability to incorporate incorporating the information in different ways. So within the platform, so information can be presented in the form of a video, audio, or text. But of course, with text, you can play around with different fonts. If there's an individual that requires a particular font, maybe it's easier to read. Things like that can be implemented. And again, in terms of making information easier for patients to understand, such an approach as well could potentially cater better to maybe some patients that might have certain cognitive impairments. So again, making sure that the clinical setup meets their needs and they're able to feel comfortable and take part. So these are some reference data sets which kind of contextualize the impact of eConsent. So again, going back to improving the operational efficiency of clinical trials, where there does tend to be quite a bit of waste. Some estimates showed that eConsent can reduce recruitment times by up to 42%. There's also a systematic literature review which covered over 13,000 patients on 35 studies, showing that patients generally had a better understanding of study information compared to conventional paper-based formats. And just to follow on from that, in terms of deviation from study protocols, so looking at average percentages, so the deviation, the percentage of deviations were slightly lower when eConsent was applied as opposed to conventional paper-based format. So again, I think the key within eConsent is the ability to package information into an easy and more easily accessible way, particularly for patients, and understanding something that they can understand in order to obtain their informed consent. So here we have a list of country-specific guidance for eConsent, so areas where they're allowed. So this was a list that was put together by Castor. So I think generally in the northwestern world, eConsent and e-signature are both accepted, with the caveats of Canada and the UK. So in Canada, so pending an ethics review for both eConsent and e-signature, it would permission would follow. And then in the UK, similarly, an ethics committee would be required before permitting the use of eConsent, but e-signatures are already permitted. So just on to electronic case report forms. So an electronic case report form is a digital version of a case report form. So similarly to eConsent, the documents are housed in a digital format and within a decentralized clinical trial platform. And so in the same way, they're used to systematically collect data on the participating patients. So with just like regular case report forms, so paper-based ones, they're very comprehensive documents that cover everything from demographic data. They can incorporate lab data, medical history, the inclusion and exclusion criteria, and essentially they capture all data parameters which are stated in the clinical study protocol. And here we have some reference values, which again show the benefits of implementing electronic case report forms. And so here we're looking at the potential to reduce administrative tasks and site costs, which can really drive inefficiencies with the conventional way of doing things. So we have a study where the total cost per patient was lower when electronic case report forms were applied. So we're looking at 374 euros with electronic case report forms versus 1,135 euros for conventional paper-based case report forms. And secondly, the time to center opening to database lock has been shown to be quicker when electronic case report forms are applied. So we're looking at 32 months with case report forms, electronic case report forms versus 40 months with conventional paper-based case report forms. So again, the potential to speed up processes and close out studies in a more efficient way. So with case report forms, here are some key advantages, so um, key reasons as to why a clinical study team would want to implement an electronic case report form. So firstly, we have reduced risk of human error. So there's no need for manual data entry, as key data fields are generally pre-approved. So for example, if you think of a case report form within a DCT platform, in some cases, the ranges for data parameters can be configured beforehand, meaning that if someone put in a number which went above or below a certain threshold, they wouldn't be able to close the document. It'll be flagged. So it's like an easy way for to curb human error. There are also some automated processes. So, for example, with Milo, which is a next generation eCRF technology, in the sense that it can push information from an electronic health record directly into an eCRF, so saving loads of time and preventing duplication of work, and in doing so, reduce the risk of human error. And secondly, data protection as a digital document, so of course with robust cybersecurity protocol, sensitive patient data will be secure. So again, making sure that the technologies are configured, developed in line with GDPR and protocol, or in line with HIPAA. And then thirdly, we have real-time management. So again, we're looking at the efficiency of operations. So queries can be edited, addressed in real time without disrupting the study processes. And lastly, so again, we're looking at cross-site study management. Again, efficiency is key in terms of having better quality clinical trials. So protocol data can be collected and monitored across multiple sites. So this is really important for complex multi-site, multinational studies where vast sets of data. The great thing about eCRF, you can house all of that data efficiently within a centralized platform. And in comparison to conventional ways of using case report forms, instead of sifting through lots of data, you can just move across different tabs in the DCT platform. Now we have ePRO. So with electronic patient reported outcomes, so we're looking at digital outcomes that allow patients to report on their health status, symptoms, quality of life, and treatment experiences. So again, these are outcomes which are quite patient-centric, speak to the patient experience and things important to them. And they're collected through hardware such as smartphones, tablets, computers, and in some instances can also make use of interactive voice response systems or SMS text. These are the key advantages of ePRO. So firstly, we have real-world data collection. So patient outcomes can be captured in a real-world context and in a longitudinal way. And this means that, in theory, the data from a patient can be collected on a continuous basis, 24/7. And the key benefit of this is that gathering data with higher granularity. If you think of a conventional way of doing clinical trials, and so for example, in a clinic-only context, the data gathered from the patient so the data that the investigator would be privy to would only be the data that's obtained from the patient within that given moment. So once the patient goes home, technically there's no view as to what the patient is experiencing. So again, the longitudinal data, granular data, And this is really important for example, assessing any fluctuations or seeing how certain environments or lifestyles can impact the efficacy of a healthcare intervention or the efficacy or how patients respond to treatment. Patient centricity. So again, outcomes which speak to the patient experience. So again, incorporating aspects related to the quality of life, and these can appear in a generic context. So you have some ePROs which are generic. So for example, the EQ5D and 5DY outcome measure. And of course, you can also have some disease-specific outcome measures which serve to speak to the specific experiences of patients of a particular patient group. And decentralized access. So in terms of providing health clinical trials that patients, the vast majority of patients can access. In theory, patients can use the platform, participate in clinical trials from any place of their convenience. It could be in their home or any other place. So as mentioned earlier, this is particularly important for those that live in rural, hard to reach areas, or again, particularly for patients with impaired motor function. They don't need to be stressed. We can bring clinical trials into their home, essentially. And with cross-site study management, so we can manipulate data in real time. So for example, if you think of a dashboard, you can choose to look at high-level aggregate data or individualized patient data. And again, with the implementation of automated descriptive statistics, this can help with answering many preliminary questions of interest. Here we have data which shows the acceptance of ePROs. So generally, the high completion rates, so compliant rates observed up to 93%. And also 94% of patients are willing to bring their own device within a clinical trial to use ePROs. So again, it's quite common for ePROs to be accessed through an app on a smartphone. So just quickly, we'll go through the challenges to decentralized clinical trial adoption. So as much as there are plenty of benefits to implementing DCT platforms, there are some barriers which still affect the extent to which they are used. So firstly, we have data and privacy concerns. So with sensitive patient data, ensuring that it's housed in an appropriate way. We have the obvious threats of hacking or sometimes third-party access, these types of things. But usually when the platforms are configured and developed in line with GDPR or ISO, HIPAA requirements, there are a lot of risks that are mitigated. Also, the cost of implementation. So the cost in some cases can run into the billions as well, which can serve as a barrier for widespread use. And we have interoperability, so connected to the cost of implementation. In fact, interoperability, one of the key drivers for high costs. So it's the ability to implement a DCT platform within an already established healthcare framework. So you can think of a hospital, they already have an EHR system and they're interested in using a new DCT platform. How do you get the two softwares to talk to each other essentially? So one of the key ways to navigate this is to develop an API to facilitate smooth integration. Or in some cases, there are There are some platforms which may offer more web-based software where there might just be a requirement for a plugin as opposed to a full-on integration. There's also patient compliance as well. So the risk of patients not being fully engaged. So you can imagine it would make sense for a patient if they're filling out ePROs in the comfort of their home. They might feel a lot more comfortable to the point where they might forget to fill out certain questionnaires or give the information required of them at certain times. But of course, again, one quick way around that is to configure platforms in a way where there are notifications pushed out for the patient in order to remind them to fill out a particular ePRO, and also the conventional way, a phone call from an investigator, that can also work quite nicely. And finally, the digital divide. So here we're looking at some of the socioeconomic challenges. So with a push towards digital in clinical trials and healthcare as a whole, and those that may not have access to the hardware required or an internet connection, those individuals being left behind, that's of course a huge, that could be a really big problem. Although a lot of clinical trials that do use DCT platforms, they have the bring your own device approach. Also, in cases where patients don't have access to a smartphone or an internet connection, this of course can be factored into the budget of a study. And also, just to quickly touch upon digital literacy, digital health literacy, which of course can be an issue and can impact how well individuals participate in a DCT-based clinical trial. In instances where that's low, study teams can provide support and training, and in a lot of cases, DCT platforms are developed and configured with patients. So speaking specifically to eConsent, eCRF, and ePRO, so to summarize the key benefits of these components that fall within DCT platforms, we have decentralized efficiency, so the ability to manage huge sets of data in a way that doesn't disrupt study processes, and also the ability for investigators or patients alike to take part as well. And also we have patient centricity. So again, the ability to incorporate outcomes which are specific to them. And also, just to touch upon the decentralized efficiency, the ability for them to take part in the comfort of their own home. So it'll be quite patient centric to drive down any indirect costs they might usually incur when traveling to a clinical study. And then high quality data. So again, we're talking about real world data here, data that can be collated in a longitudinal way. And of course, just to quickly touch upon eCRF, data with minimal errors, data that can easily be housed within a centralized platform, incorporating the vast sets of data from different clinical study sites. Okay, thank you for listening. So I think we'll go to the questions, if anyone has any. Sullivan? think we've got one hand. We've got one hand up. Here we have one. Yep. So if you can put it in the chat box, that will be helpful. There's a hand raised. So, or no questions? Okay. All right. Thank you. So I think there were some connection issues there. Yes, sorry about that. So yeah, we do have a hand raised. Please. Okay. Okay, so first question. So in terms of e-consent, why are they not allowed in some countries and what does it depend on? So usually the parameters would usually depend on the I guess the regulatory requirements of the country. So for example, each country will usually have um, their own authority which will oversee certain clinical projects, and they would base they'd base the decision to allow or to disallow e-consent or e-signature on that. So this can be quite broad. So, for example, in the UK, the NHS Ethics Committee would have their own approach, and it would be dissimilar to other countries in Europe or elsewhere. Okay. Any other questions? And just to quickly follow on in terms of the specific requirements. So, of course, once the study site is decided upon, and then, of course, that can be thoroughly reviewed in order to ensure that the requirements of or the pathways required within that country are followed in order to get the outcome of the e-consent or the e-signature function being permitted. Okay. Any other questions? So I think, yeah, that's the only question. Thank you all for attending, and for any information on the services that we provide. So as mentioned earlier, we do have service offerings that cover the navigating and MDR regulation, so helping get your medical device to market, or you would like to explore how our Milo Healthcare DCT platform can be used to conduct your decentralized clinical trial. So this could be for any purpose spanning PMCF activities, or maybe for a regular drug trial. Please get in contact with myself here, or also clientcare@eclavar.com. Thank you.